Hello everyone, I am Dr. Maitri Shankar from Bengaluru, India. At the outset, I would like to thank Women in Nephrology India for giving me this opportunity to present on this year's World Kidney Day theme. World Kidney Day Steering Committee has declared 2024 the year of kidney health for all, advancing equitable access to care and optimal medication practice. The 2024 campaign will focus on raising awareness about the importance of ensuring equitable access to appropriate treatment and care for people living with kidney disease in order to improve their quality of life as well as delay the progression of the disease. If you look below here, you can see that the logo has been revamped. The above one is the newer logo and the below is the old logo. In the old logo, we can see three colors. Blue stands for water, yellow for urine and red for blood. If you look at the new logo, there is a new color that has been added, which is the color green, which represents sustainability, a core value that has been embraced by the nephrology community around the globe. Let's look at some fascinating facts about kidney disease. Kidney disease is not uncommon. In fact, it is very common. 1 in 10 people worldwide are living with kidney disease. Global mortality from all kidney diseases may actually range between 5 and 11 million per year, especially in low resource settings. Kidney disease is the seventh leading cause of death, and it is projected to be the fourth leading cause of death in the year 2040. Diabetes and hypertension are the most common risk factors. 1 in 3 people with diabetes have chronic kidney disease. 1 in 5 people with hypertension have chronic kidney disease. Unfortunately, 40% of those with hypertension and 60% of those with diabetes are unaware of the diagnosis. When we look at all the causes of chronic kidney disease put together, 80 to 93% of the patients were unaware of chronic kidney disease. It is obvious from these figures that chronic kidney disease is a silent disease and patients don't develop symptoms until the kidney disease is advanced. So why is it important for us to detect and treat chronic kidney disease early? Of course, it increases the morbidity and mortality rates if not detected early. At the same time, chronic kidney disease also poses a significant global economic burden. If you look at the cost of dialysis, it ranges between 24,000 to 48,000 Indian rupees per month. The cost of transplantation varies from rupees 5 lakh to rupees 15 lakhs depending on whether you're getting the transplantation done in a government setup or a corporate setup. Additionally, patients with chronic kidney disease have multiple comorbidities such as diabetes, hypertension, and associated complications such as anemia, mineral bone disease, acidosis, and so on, which requires medication. The cost of these medications comes up to anywhere between 10,000 to 15,000 Indian rupees per month. Even the cost of post-transplant immunosuppressive drugs comes up to around 10,000 to 15,000 rupees per month. Added to this, we all know that patients with chronic kidney disease are immunosuppressed. They are prone for pulmonary edema, they are prone for infections, they are prone for fractures, and so on. Also, they are at higher cardiovascular risk. So that would mean a higher risk of hospitalization. So if there's any added hospitalization, that would again add to the burden of existing costs. Data from many low resource settings are absent, but most costs are paid out of the pocket. And this degree of cost or this degree of expense is stressful even for people from upper middle class. It is alarming to know that the cost is higher than the per capita GDP of India. Early diagnosis and prevention of chronic kidney disease could save our Indian health system 850 billion Indian rupees over a span of 20 years. The core aspects in preventing chronic kidney diseases is maintaining a healthy lifestyle. Avoid smoking, limiting alcohol intake, and an active lifestyle, minimum of 30 minutes of exercise per day for 5 days in a week. Prevention and control of risk factors, diabetes, hypertension, and obesity. Keep the blood sugars, blood pressure, BMI under control. Optimization of maternal and child health. Postpartum sepsis and preeclampsia are the most common causes of obstructive acute kidney injury in India. Postpartum sepsis can be easily prevented by following safe surgical practices. Appropriate antenatal care with monitoring of blood pressure, kidney functions, urine routine is important to detect and treat preeclampsia. Addressing social and structural determinants of health, such as poverty, unemployment, racial discrimination, discrimination based on caste, creed, and sex, can also limit the accessibility of patients to healthcare services. Mitigation of climate change. Over the last decade, there have been many case series of CKD-U. U stands for unknown etiology from hot regions of India, such as Telangana, Andhra Pradesh, parts of Tamil Nadu, and Orissa. It is most commonly among the farmers who work hard under the sun with limited fluid intake, leading to repeated episodes of acute kidney injury due to dehydration, ultimately progressing to chronic kidney disease. Keeping oneself hydrated and drinking approximately 2 to 3 liters of water per day is important to prevent kidney injury. Avoidance of acute kidney injury. Other common causes of acute kidney injury, infections. India is a tropical country and we are prone for tropical infections such as acute gastroenteritis during summer months, leptospirosis, scrub typhus, malaria, dengue. If not detected early and treated, they may progress to multi-organ dysfunction syndrome causing acute kidney injury, even leading up to kidney failure and requirement of kidney replacement therapy. Avoidance of usage of alternate forms of medications which might be high in adulterated heavy metals such as mercury, arsenic, strontium, cadmium, and so on, and avoidance of abuse of painkillers, especially NSAIDs. People are dying because of missed opportunities to detect chronic kidney disease early and to deliver optimum care. So early diagnosis and treatment becomes very important here. Hence, time becomes very important here. We cannot afford to lose time. Strategies to prevent and treat chronic kidney disease have been built on a strong evidence base over the past 3 decades. Clinical practice guidelines for chronic kidney disease are very clear. They are freely available on the KidneyGo website. They are easy to follow. So the guidelines are easily available, evidence-based, and easy to follow. But why are we still having millions of deaths because of chronic kidney disease? The key question here is, are these guidelines being implemented? Implementation is the key factor here. If you look at the real world data from electronic health records, you can see that there is a huge gap between knowledge and implementation in kidney care. If you look here at proteinuria monitoring in patients who are aware of chronic kidney disease diagnosis is only 50%. Hardly 35% have their blood pressure under control and hardly 60% have their HbA1c under control. RAS inhibitors were proven to retard the progression of chronic kidney disease 15 years back. But look at their usage now, hardly 35%. SGLT2 inhibitors were recently approved to retard the progression of chronic kidney disease. They work like wonder. They are wonder drugs. They are also called as flozins. You would be surprised to know, for every 1,000 patients treated with SGLT2 inhibitors, we can avoid 83 deaths, 19 heart failures, 51 dialysis initiations, 39 episodes of acute kidney injury. But if you look at their usage, it is dismal, less than 10%, hardly 5%. Expert lifestyle and dietary advice, hardly around 20%. SGLT2 inhibitors, RAS inhibitors are something like, for example, advising angioplasty and stenting for someone with acute MI. You just cannot get away by not advising them angioplasty. Similarly, you just can't get away without prescribing SGLT2 inhibitors with anybody with diabetic nephropathy or other types of chronic kidney disease. So you have seen from RAS inhibitors that it takes approximately 17 to 20 years for new treatments to move from research to clinical practice. With millions of people dying with chronic kidney disease each year, don't you think 17 years is far too long for all of us to wait? We have to act now to bridge this implementation gap. The implementation gap is huge. In the era of internet, where we have the world on our fingertips, 17 years is way too long for all of us to wait. What are the reasons for this huge gap in implementation and community of continuity of care? First and foremost, it is the cost. Many of the patients may find the medications expensive. Even if it is generic medicine, it may not be easily available. So accessibility and affordability are the issues here. Second is lack of patient education. Some of the patients may just stop taking medications on their own, thinking that they are feeling fine. Mind you, chronic kidney disease is a silent disease. Educating patients about the importance of continuing medications and regular follow-up is very important. Polypharmacy. Patients may get confused due to the huge list of medications and they may just stop taking the medications. Also, fear of adverse effects may compel the patients to stop medications on their own without consulting their physicians. In low and middle income countries, the gap between evidence and implementation is even wider, given the higher cost and inconsistent availability of these medications. Such gaps in delivering optimal treatment for patients with chronic kidney disease are simply not acceptable. So we have to bridge the gap. And how do we do it? Let's look at our health policies and health systems first. Kidney health has not been prioritized in our health policies. It's usually cardiovascular diseases and malignancy that is given more significance. It is a good thing, but at the same time, the impact of kidney disease is equally huge. We need strong advocacy to prioritize kidney health in our health policies. CKD is only incorporated into non-communicable disease strategies in approximately 50% of the countries. Policies are required to integrate kidney care within the essential health packages under the universal health coverage scheme such as the Ayushman Bharat. Not just that, the health system must be strengthened and quality of care must be prioritized, as poor quality of care again contributes to more deaths than lack of access alone in low resource settings. Here is a list of medications that are essential for patients with chronic kidney disease. Across 18 countries, 4 cardiovascular disease medications, statins, ACE inhibitors, aspirin, and beta blockers, all often indicated in chronic kidney disease, were found to be more available in private settings than in public settings, mostly unavailable in the rural areas, unaffordable for 25% of the people in upper middle income countries, and 60% in the low income countries. So, steps must be taken to provide these medication at national levels under the Universal Health Coverage Scheme. Also, strict directions must be given to the pharma companies to provide these essential medications at affordable prices. Include essential medications and basic diagnostic tests such as kidney function test and urine routine in the Universal Health Coverage Scheme. The quality of generic medications, especially in LMICs, is an additional barrier. Regulation and monitoring of drug manufacturing and quality standards are also important. In the early stages, CKD is asymptomatic. Targeted early screening of those at high risk, that is, people with diabetes, hypertension, cardiovascular disease, family history, and obesity, is very important and offers the potential to significantly reduce the morbidity and mortality from chronic kidney disease and also its complications. Unfortunately, only 25% of the countries have CKD detection programs based on national policies or guidelines. Our states and country should include screening for kidney health in their health policies and guidelines. Recognizing potential symptoms are also equally important. Screening is done by measuring blood pressure, serum creatinine, urine analysis, and urine albumin or protein to creatinine ratio. This entire exercise hardly costs anything, maybe not more than 100 rupees. Early detection of chronic kidney disease will lower the costs over time by reducing the complications of chronic kidney disease and kidney failure, requirement of dialysis, requirement of kidney transplantation, and so on. Screening for kidney diseases, early identification of those with kidney disease, and treating them to prevent progression of chronic kidney disease is the best way forward for developing countries like India, where resources are limited. We cannot afford to use up our limited resources in establishing more and more fancy hemodialysis units. The cost of hemodialysis is only going to increase, and also we will have to deal with the perennial problem of water shortage. Looking at healthcare professionals, there is a shortage of primary care physicians, shortage of specialists, nephrologists, neurologists, cardiologists, especially in Tier 2 and Tier 3 cities. On top of this, we are pushing for brain drain by not paying them adequately. Reduce the time pressure, especially true in government hospital outpatient departments, where the number of patients to be attended are far more than the healthcare workforce can handle. This leads to excessive workload and clinician burnout. Improving clinician patient ratio may overcome this barrier. Many knowledge gaps also exist regarding chronic kidney disease, especially among primary care clinicians. And such gaps are remediable with focused public and professional education. In some instances, we can also take the help of pharmacists, for example, to identify people with diabetes or hypertension and those at risk of chronic kidney disease based on the prescriptions that they bring to the pharmacy. They could offer testing on site and they can refer the patients if needed. Mobilization of community health workers and Anganwadi workers may also facilitate in early detection, diagnosis, and management of chronic kidney disease. According to a study from Indian Express, the top four causes for the great resignation, the top four causes for brain drain were low salary, limited career and research opportunities, not being valued by leadership, and unhealthy relationship with colleagues. So it becomes a responsibility of the administration to look into each of these factors and improve working conditions of the healthcare professionals. Health literacy. Self care is the most important aspect in kidney care. A patient should have the ability to understand his or her health needs, make healthy choices, feel safe and respected in the health system, and also have psychosocial support for important decision making. The doctors should communicate clearly to the patient and the patient party regarding the condition of the patient, the importance of taking medications, the importance of follow up, and also the cost of the medications, the cost of dialysis, the cost of transplantation if at all it is required. To overcome barriers and to promote equity, patient perspectives are also essential to designing and testing better health strategies. So it is best to involve them in designing research and clinical trials. There are multiple methods to look at the patient perspective. We can do interviews, we can do focus group discussions, surveys, even simple conversation might be useful. The journey of each person living with chronic kidney disease is unique and their voices must be heard. Polypills are very attractive. These polypills are fixed doses of several guideline recommended medications that are presented in one tablet. It reduces the cost, it lessens the pill burden, and it is very simple to administer. These are the way forward. Using digital technologies, integrating telehealth and other types of remotely delivered care are important to improve the efficiency and reduce costs. Electronic health records and registries can also support monitoring of quality of care and identify gaps to guide implementation and improve the outcomes. Artificial intelligence may also be harnessed to risk stratify and personalize medication prescribing and adherence. There are many apps that can remind the patients to take their medications. They can remind about the follow-up visits and so on. Telenephrology can be used for communication between primary care physicians and specialists. There are barriers for equitable access to care and optimal medication practice, but we can take steps to overcome these barriers. Comprehensive healthcare delivery, integrating kidney care into our existing healthcare policies, empowering our healthcare professionals, empowering our patients, and patient advocacy groups may help in mitigating these barriers. Your support is vital. The support of general practitioners, general physicians, obstetricians, cardiologists, nephrologists is very vital. My only take home message to all of you is that please check kidney function tests and do urine analysis to all the patients who walk into your OPD. Early detection and treatment helps a lot in retarding the progression of chronic kidney disease. Thank you so much.